talking about the next topic, which is the solving the puzzle of mesenchymal stem cell in osteoarthritis. So, have published during the COVID situation some good paper on stem cell, enhancing the regenerative medicine, how it's helping in severe corona infection. And then this is our latest paper, because if you have some interest in regenerative medicine, and you basically go to different site, PubMed, Google Scholar, or any platform, and you try to learn about the stem cell, you come across different pieces of information, and many of the time it is confusing, and it's difficult to join those confusing puzzles, and to get a clear understanding and idea like what actually mesenchymal stem cell and how they are working. So this paper basically we wrote, which was published in September 2020 in PubMed and American in Archive of Bone and Joint Surgery. So in this paper, basically we have combined all the available latest possible information on stem cell, how they work, and what is their mechanism, issue about nomenclature. So this talk is about based on that paper only. So most of the information is from that paper. You can go through this. So it was basically 1969. Kaplan was the first person who gave this popular term, which is called mesenchymal stem cell or MSC. And over the next few decades, this term was commonly used during research, publication, and in scientific community. And many of the time, it was also misused. So then, because of the misuse or overuse, in need, basically there was a need, what actually are the stem cell? Because a lot of confusion was there regarding their nomenclature, their characterization, and whether they are really stem cell or not. So these two issues, the issue of characterization and stemness, was taken up by International Society for Cellular Therapy. And what they said that the mesenchymal stem cell are not the stem cell, but they are the stromal cells. The stromal cells are basically the cells which promote healing and which are present in most of our tissues and body parts. So they said they should be called mesenchymal stromal cell, not the stem cell. They also gave some guidelines that you can label a cell as a MSC only when they show a plastic adherence during culture medium when you are growing them, and more than 95% of them they should be positive for these three markers, which is CD90, 73, and 105, and they should be negative for CD34, and also the other marker like CD11, 79, and 19. And they must be able to differentiate into the osteoblast, adipocyte, and chondrocyte, like from one cell origin to these three cell lineage in a standard in vitro condition. In 2017, the Kaplan again revisited his initial concept of mesenchymal stem cell, and he agreed with these guidelines that okay, it is not a stem cell, because stem cells should show on serial transplantation, it should double by cell renewal. But it was not happening when you inject the stem cell into affected area, like in vivo or inside the body. But he did not agree that the MSC is derived from the connective tissue layer, that it's a stromal cell. No. So he basically advised or recommended another name for the MSC, and he gave it medicinal signaling cells. And he basically proposed that since we know stem cell, they work by secreting growth factors, cytokines, which promote healing at the site of injury or inflammation. So they should be called as medicinal signaling cell, because they are giving signals to the inflamed or damaged area and promoting healing. Despite his recommendation, still in the literature, the MSC is one of the most common term, which is still being used. So we propose based in the current literature and how the stem cell behave, and in this paper, that I think the maintenance stem cell should be a proper terminology to describe these cells rather than mesenchymal stem cell or stromal cell, because mesenchymal means the mesodermal. Their origin may not be just from mesenchymal. Now, with the ongoing research, we know your stem cells are available not just in the mesoderm, they're also available in the ectodermal tissue like neural tissue, and of course, mesoderm and endoderm, like lining of the intestine and other internal organs. And now we are able to demonstrate that the stem cells are also there. So, to just label them mesenchymal may not be a good term. And why we should call them maintenance? Because we know in vitro study we have shown that, like if you take a stem cell from the fat or from bone marrow, in vitro still they are able to convert into different cell like bone osteoblast, chondrocyte, adipocyte. But inside the body, when they're implanted, because of some reason it's not happening, but still now there is evidence in few paper that it's happening. So what they are doing, they are basically maintaining a environment by which promote healing and regeneration. So that's why we propose that they should be called as maintenance stem cell. If you see the role of osteoarthritis, uh, basically in osteoarthritis, the basic problem is the cell mediated damage. Now, these cells, usually the primary, initial, or the central role of pathogenesis is by these three cells: macrophages, mast cell, and natural killer cells. All these three cells are basically starting the process of osteoarthritis, and then later on the acquired cell immunity, T cell and B cell, they join these cell and establish is like it is like a chronic debilitating joint and synovial pathology. So basically, in osteoarthritis, there is a more catabolic environment, which is an anti environment. There is an increased level of interleukin 1, we already know, alpha 2 necrotic factors, and certain metallopeptidases, which cause degradation of the cartilage by increasing the level of interleukin 6 and interleukin 8, leukotriene inhibitory factor, and leading to the osteoarthritis of the knee. Now we propose a mechanism that once you inject a stem cell, what actually happened? So in this mechanism, first we need to understand that in our body there are two kind of environment. One is called pro environment, another is called anti environment. In pro environment is basically anti apoptotic, which means that normally our body has a capability for a programmed cell death at a certain point of the time. So in pro environment, that apoptosis is not happening. It's an anti-inflammatory environments, and if there is inflammation, it is still going. It is anti-fibrotic. It's not like an inflammatory scar. It's more like a healing and angiogenic. In the another environment is anti-environment, in which opposite of all these four processes is happening. And there is always an imbalance between pro and anti-environment, which lead to the structural changes, whatever may be the initial process, injury, tumor, trauma, congenital. These two environment are interacted and which lead to the final outcome. Now, then we need to understand that in most of our body parts and organ, there are stem cells which are called local resident stem cells. And these stem cells, they are active, functional, and they are working. That is the reason that our intestinal lining is replaced within few weeks, full intestinal lining. Same happen with our skin, but we are not seeing it. So who is doing that? That is being done by the local resident stem cell. Now, these local resident stem cell, whenever there is an unhealthy tissue because of aging part, trauma, disease, they become weak. They have less energy, they are not releasing growth factor and cytokines, and they are dying. And during this phase, because of these reason, then we need a stimulus from outside which goes there and help these local weak stem cell. So when you implant a stem cell, basically there are three steps happen. The first step is called first induction response, which means when you inject stem cell, only a small percentage of them survive, and most of these stem cells they die. But before dying, they do their work. How? By releasing growth factor, cytokines, and extracellular vesicles. Now these growth factor which have been released and the surviving stem cell which have been injecting, they start the healing process. So they start this FIR, which means F is they facilitate a pro growth environment by releasing growth factors, cytokines, chemokines, and this is basically by paracrine and juxtacrine mechanism. Everybody knows this. Now by this, they induce the local weak stem cell by signals, by energy, and by local support. And they basically wake up these sleeping stem cell, hey, that you need to be active, you need some support, and follow us. And then these local stem cell start following these surviving stem cell. Now this lead to the recruitment of new stem cell, which is happening because of proliferation which is limited. There is a limited self renewal, proliferation and differentiation from the implanted stem cell and by the local resident stem cell, which increase the number of stem cell. Now in the second step, this sustained induction response continues, and because of sustained release of growth factor, cytokines, exosomes, and there is a more induction of local resident stem cell. And now the local resident stem cell are the most active during this phase because they are more in number because they are dividing and they have more energy through the exosomes from MSC. They have more signal, and environment is favorable because it's like a non-inflammatory environment, anti-apoptotic environment, and this environment is promoting the healing. In the third stage or the third step is called limited induction response. After some time, once the growth factors from the implanted stem cell or those who have been released from the implanted dead stem cell, they start getting reduced in number or the availability, and the stimulus to the local resident stem cell become less. And because there is a lack of continuous supply, the local resident stem cell again start becoming weak because now the number become less, energy is less, signal is less, and growth factors are also reduced in number. So in if we put in a flow diagram, when you put a stem cell, it start first induction response, then it continue and then limited. Now if you want this cycle to continue, you need to repeat the stem cell injection. And we already know that how the stem cell they work. The main mechanism is basically through the trophic, which means growth factors, healing, and immunomodulation. So how stem cell are working in osteoarthritis? Stem cell are basically inhibiting the inflammatory cytokines, anti-angiogenic factors, and apoptotic. So basically, they are promoting a non-inflammatory environment. The macrophage is the central cells, as we already discussed in the last slide. So there are two kind of macrophages, M1 which promote inflammation and another is M2 which is immunosuppressive. So these stem cells they convert M1 conversion into M2 by so M2 is basically more immunosuppressive. Now this is mediated by a gene protein called TSG, alpha tumor necrotic factor stimulated gene, which is responsible for this action. It also acts on CD44 on macrophages, and it prevent or reduce the production of inflammatory mediator from macrophages, nitric oxide, tumor necrotic factor, and interleukin 1. It also prevents the mast cell degranulation. So, which means stem cell is working in all the three cells or central mechanism which start or which contribute to the osteoarthritis. Now, another important function of stem cell is basically the immunosuppressive effect. So they create an immunosuppressive environment. They basically promote secretion of interleukin 10 and beta transforming growth factors. These two factors basically prevent the release of interleukin 1 and alpha 2 necrotic factors, which from the macrophages on stimulation of LPS. Then they also act on the T cell. So basically, they prevent gamma interferon mediated T cell proliferation, and they also block differentiation of macrophages towards the dendritic cell. They also inhibit the division of B cells. So they are working on cellular level, T cell and B cells, and also along the innate immunity level. So in osteoarthritis, MSC promoted pro-environment, and they also upregulating the senescent cells which are metabolically not so active, and making them more active through the exosome, energy and signal. Now next question come, which a lot of patients ask or even the regenerative practitioner, do stem cell really work in osteoarthritis? If we see the literature, it's quite conflicting and debatable. Most of the studies show that the stem cell it improve the quality of the life by improving the pain score, by improving the different score as per the joints, like for WOMAC score and function in comparison to the placebo or the conventional treatment like viscosupplementation, PRP, or other autologous condition serum. And usually this effect lasts for 6 to 12 months, and then it starts showing a downward trend. But there are some study which show that the effect can continue even up to 2 year, 3 year, even up to 4 year. Then the next question comes the doses. In literature, we find that the dose is quite variable from 5 millions to 50 millions. And it also shows, if you go into detail, that both high dose and low dose, they have beneficial effect. Now, in literature and in practice, you see different route of administration, but the most common route is basically intra-articular. Now, does stem cell make any difference in the X-ray or radiological improvement is there? No. Most of the studies show that there may not be any improvement in the joint space, and the angle between femur and tibia with weight bearing, it may remain the same. But lately, in some studies and even in our practice, we have seen that there is a slight improvement in X-ray in the joint space, but we should always take the X-rays in the same, preferably with the same machine, same place, and with the same position. Then only you can make a comparison between the pre and the post treatment changes. Same happened with the MRI. Now, usually MRI changes are seen at 1 to 2 years after the treatment, and in some patient there may not be a significant improvement. And changes are also more seen if you combine with a surgical treatment like STO. Are there any side effects for the stem cell? Well, usually the most of the general public or physician, they are skeptical about the cancer, whether the stem cell treatment cause cancer or not. Well, until now, we know that there are two kind of stem cell, that embryonic stem cell, adult and induced pluripotent. Now, pluripotent stem cell, which are embryonic or iPSC, we know that there is a problem in controlling, their multiplication when you inject inside the body, and they have shown formation of teratoma. But with the adult stem cell, when you take from fat or from bone marrow, until now, there's no report of any malignancy, and some report even, criticizing that we should not link adult stem cell with the cancer formation. but still we need long-term follow-up. In most of the cases, the most common problem which we see is just transient pain and swelling in 50 to 60% of patients. Some patient may lead to the dehydration. Now, if we go through the literature, serious complications are very rare, and if they have been reported, they are not directly linked with the stem cell, like like the pulmonary embolism. But when you take the stem cell from the abdomen for the fat or from the iliac crest, there are some report of the infection and some effusion in the knee, which lasts for few days. What about the safety? Now, whatever the complication or the side effect we saw in the last slide, if we follow a standard, safe, and aseptic technique for harvesting the cells, and if you are using a culture expanded, and if you are using a good quality control and following the minimum, the requirement for the culture and expansion, you can avoid them. And theoretical risk of the cancer formation is still there. Many people, even in the doctors and scientists, they see that stem cell should not be used, but lately many studies have rejected this claim of the tumor formation. So, what are the future perspective? Future perspective is now we know that the stem cell, when they are outside the body, they can convert into fat, bone, muscle, or different areas, even from neurological and other area. But the problem is once we implant inside the body, then they actually do not convert, or if they convert in a very limited environment of proliferation. So the research is going on what actually happened that in the local environment the stem cell failed to perform. It's doing the same action outside, but inside our body is not. So we need to standardize that what should be the site of the injection. In osteoarthritis, it's intra-articular, and now we know that the pathology is also not just inside the joint, it's also happening in the now latest studies are showing that there is a subchondral talk between the cartilage and the bone. So some studies are now showing that we should inject the stem cell not inside the joint, also at the subchondral, like an intraosseous drilling. We are doing this practice in some of our patients and also in infra and suprapatellar fat. Optimum dose range from 1 million to 1 billion, but the minimum dose as low as 2 million has been shown is effective. Some people say ideally we should give between 20 to 40 millions. Now, once you inject a stem cell, the fate of the stem cell depend upon the the local environment. So that's called a stem cell niche. So it's very difficult to basically form a stem cell niche in a damaged area. So now the research is going on how to deliver in the form of encapsulated or combined with the scaffold so that they can stay there longer and they can work longer. So this is the last slide of my presentation, and we have leading practitioner all over the globe, and they're contributing and they are providing latest evidence-based information, which is free from commercial interest, personal bias. So now let me see if there are any question.